Hi folks, this is Dakota, and today we're going to discover how to use the Herbal database to get off of psychiatric drugs. You know, there's a growing skepticism towards psychiatric medications and a growing interest in withdrawal and alternatives. The database has so many resources to help you reduce or get off of them altogether. Now, when you look at the left side of the screen, you're seeing the various topic labels. They're linked together to help you discover other relevant information. And on the right side of the screen, I'm showing you some of the content found in the active label that's seen in the central position on the left. Using the search box, we can look up antipsychotic drugs and start to drill down. So let's go to antipsychotic drugs, which are also called neuroleptics. One of the PDFs located here launches us right into the question about relying on such drugs for treating psychosis. Another reveals the risk they pose to elderly patients. If you're currently using a neuroleptic drug and want to know if any herbs might interact with it, check the interactions. Here, for example, we discover that folks using lithium should avoid nettle. Or you may want to read up on the typical and atypical antipsychotics here. But let's use the breadcrumb trail located at the bottom of the screen to go back to where we started. And from there, click on Psychiatric Drug Withdrawal. You see right off the bat a couple of good books to get you started. Coming Off Psychiatric Drugs, Successful Withdrawal from Neuroleptics, Antidepressants, Lithium, Carbamazepine, and Tranquilizers. And there's Your Drug May Be Your Problem, How and Why to Stop Taking Psychiatric Medications. Another great source is provided by Dr. Peter Breggin. He's sometimes been called the conscience of psychiatry. He was originally a Harvard-trained psychiatrist and former full-time consultant for the National Institute of Mental Health. He started his career over 60 years ago, and for decades, he's led efforts to try to reform the mental health field here in the U.S. and the UK. He's led the way in providing more caring and holistic ways of providing care for those in mental distress. A key discovery he's made over the years is that what people really need is care, attention, and love. He's written over 20 books and continues in private practice in Ithaca, New York. So here you're going to find a regular podcast that he does. He offers a course on drug withdrawal along with other guidance. There's also an International Institute for Psychiatric Drug Withdrawal. So this is really interesting. I'm going to take some time to go through this. In 2018, Robert Whitaker came out with a review of research into drug withdrawal. He found that the research centered on these three models. And we're just going to go through some of this. You can read the full PDF in the database. So the three models are the disease model. The drugs are treatment for a disease, and thus researchers study relapse rates when the drugs are withdrawn. The researchers are also assessing the return of illness in the absence of treatment. Then there's the addiction model. In that one, psychotropic drugs are understood to induce compensatory adaptations in the brain, and thus withdrawal is understood to be a process involving the brain seeking to renormalize its neurotransmitter pathways and other functions. And then there's the lived experience model, where those who have aimed to get off of their medications tell of their experiences, and these can vary greatly from individual to individual. According to the disease model, the fact that placebo patients relapse more frequently is taken as evidence that the drugs provide a long-term benefit since they reduce the likelihood that the disease will return. Relapse is really quite interesting. We discover that it's the psychiatrist who determines if relapse occurs. As you see here, most of the time, it's by clinical judgment. Admission to a hospital is way down at the bottom. When we look into these relapse studies, we see that in 54 of the 65 studies, the antipsychotic was abruptly withdrawn. only 3 of the 65 studies even assessed the patient's quality of life, and although relapse rates were lower in the drug-maintained group, 70% of this cohort either failed to improve or worsened during the study. In inpatient studies, only 5% of the drug-maintained patients were discharged. Now, according to the addiction model, psychiatric drugs perturb neurotransmitter systems, and that causes changes in receptor densities. During the withdrawal process, these receptor densities have to renormalize, and that may take an extended period of time. So, withdrawal symptoms can vary by receptor type and the half-life of the drug. Now, here we see an illustration of dopamine function before exposure to antipsychotics, and here we see what it looks like after exposure to antipsychotics. The brain increases receptors to compensate for drug blockade. So, a return of symptoms may be a withdrawal symptom. Long-term use of drugs that suppress certain neurotransmitters is thought to cause a compensatory increase in the number and/or sensitivity of the relevant receptors. That's a concept of supersensitivity. And when these receptors are no longer opposed by the drugs, there's overactivity of the neurotransmitter or the systems involved. This can result in characteristic discontinuation syndromes and may cause rapid onset of psychosis, called antipsychotic withdrawal, and may act as a source of pharmacodynamic stress, which increases vulnerability to relapse. Drugs can affect different receptor sites. Here we see, depending on the receptor, what kinds of adverse events and withdrawal effects we can expect. The understanding is that with gradual withdrawal, the receptors will more gradually return to normal densities, and that this will reduce the risk of relapse and the severity of withdrawal symptoms. The big question is, do receptor sites always renormalize? An example comes from tardive dyskinesia, which I talked about in the previous video. So we know that antipsychotics can cause tardive dyskinesia, and the severity has been found to be associated with an increase of dopamine receptors. However, in adults, tardive dyskinesia regularly persists after the offending antipsychotics withdrawn. Studies have found that the dopamine receptor levels remain abnormally high in such patients. In my previous video, I showed how ginkgo can reduce these tardive symptoms. So if you look up tardive dyskinesia in the database, you'll see how ginkgo and other agents can reduce these tardive symptoms. And what benzodiazepines do is they induce a down-regulation of GABA receptors in the brain. We've talked a lot about GABA. It inhibits neural activity, and thus, on withdrawal, there's a deficiency of this brake upon normal neuronal activity. The fact that some long-term users of benzodiazepines suffer from protracted withdrawal symptoms is probably due to the failure of the GABA receptors to return to their normal state. The big worry is that continued drug treatment may induce processes that are the opposite of what the medication originally produced, and this can cause a worsening of the illness, continued for a period of time after discontinuation of the medicine, and may not be reversible. Now, there are some flaws in the addiction model. First of all, psychiatric drugs act on more than one receptor type. There are feedback loops in the brain that cause perturbations in one neurotransmitter system to cause changes in other neurotransmitter systems, such as the feedback loop between dopaminergic and serotonergic activity. In the same class of drugs, individuals may have different binding profiles and varying half-lives, which lead to varying withdrawal symptoms. In the current era, patients often take several classes of psychiatric drugs. and there isn't a model that explains the physiology of brain changes caused by polypharmacy or the possible renormalization of neurotransmitter systems following withdrawal from multiple drugs. Another major point is relapse needs to be distinguished from withdrawal symptoms. Now, there is a proposed model for distinguishing relapse from withdrawal symptoms. With withdrawal symptoms, first of all, new symptoms common to withdrawal of CNS drugs, new symptoms common to withdrawal by receptor type, rebound, that's the return of original symptoms at a greater intensity than the original, persistent post-withdrawal disorders, a return of original symptoms at greater intensity, or emergence of symptoms of a new mental disorder. Now, with a relapse or recurrence, the same episode returns, and the symptoms are similar to the original episode. In this PDF, you'll find this chart showing what are the typical withdrawal symptoms for antidepressants. It also talks about a number of studies that have been done on withdrawal. Check this out. None. No studies on withdrawal from antidepressants or antipsychotics. The PDF goes on to report on the experiences of those who do withdraw. There was an Australian survey of 88 patients, and this is that third model that I spoke of in the very beginning about the patient experience. So in terms of what the prescriber communications were like, you see here nearly half of the sample reported they weren't sure if their prescriber had given them any information about the proposed length of their antipsychotic treatment, or of those who did recall the topic being raised, 73% say they were told they would need to take an antipsychotic indefinitely or for life. Over half of the sample reported they couldn't recall being given any information about what might happen if they discontinued their antipsychotic abruptly. Only 10 people reported that they were informed about the possibility of discontinuation symptoms others than relapse. And here we can see how many attempts they made at getting off the drugs. The reasons they gave for stopping antipsychotics are listed here. 54% didn't like the adverse effects. 43% didn't like the idea of being on them long term. 35% felt better and didn't need them. 19% said the drugs weren't useful. And only 19% said they were advised to come off of them by the doctor. And here's a chart showing how quickly or slowly they got off the drugs. And this chart shows us what the reported discontinuation symptoms were, the general categories. The most common specific withdrawal symptoms they reported were difficulty falling asleep or staying asleep, mood changes, an increase in anxiety and agitation, an increase in hallucinations, delusions, and unusual beliefs, difficulty concentrating and completing tasks, increases in paranoia, headaches, memory loss, nightmares, nausea, and vomiting. And then they were asked who were the most helpful people to support you when you were going through your withdrawal. And this chart breaks it down, showing that the most helpful person was the psychiatrist. Quite a few of them show that nobody was helpful. And they also reported on helpful activities, so exercise comes out on top. Also, relaxation, creative activities, reading, and some said nothing. So in terms of outcomes at the time of the survey, remember these are 88 people, over 20% had no antipsychotic use. A full 50% were still on antipsychotics, and the rest didn't disclose whether they were or not. So we have a lot more to cover, and I'm going to leave reading the full paper up to you. An excellent video by Dr. Bragan is shown here, where he discusses chronic brain impairment and psychiatric drug withdrawal. This is really entertaining and goes on to tell the whole story, how we got to where we are now with drug therapy. this paper discusses what's called a harm reduction approach in mental health, and it presents a planned non-adherence harm reduction intervention for people when they are going off of these drugs. Stopping antipsychotics suddenly without support can result in harmful reactions and possible readmission to the hospital. The non-adherence harm reduction approach aims to reduce the harm of stopping antipsychotics by informing and supporting those who make this personal decision. They publish this guidebook to help people through the process. And here's a worksheet that helps people to track their symptoms while they're undergoing withdrawal. In the database, you'll also find this video describing a drug withdrawal course that you can take through MAD in America. You'll find more withdrawal resources here. And be sure to read this article by Chaya Grossberg on 10 things I learned in 5 years consulting with people coming off psych drugs. The database will link you to her site, and in particular this area where she discusses nutritional and creative alternatives to psych meds. Then we have basal therapy. It provides help to those who want to become drug-free, and the key element here is exposure to unwanted internal experiences, referred to as existential catastrophe anxiety. They examine the patient's psychosocial functioning at least 2 years after completing the inpatient therapy. This is a psychosocial inpatient therapy form specifically developed for patients with severe and composite mental disorders. Those who are admitted tend to have a treatment history that includes numerous or lengthy inpatient admissions in mental health care, long-standing use of psychotropic drugs, polypharmacy, that's permanent use of 2 or more psychotropic drugs simultaneously, and extensive use of coercion. Most of them are described as treatment-resistant after having gone through 2 or more treatment attempts adequate for their diagnosis, and including psychotropic drugs with no improvement. For those who wish, they can receive help to become drug-free. Basal exposure therapy is based on the assumption that serious mental disorders are sustained by avoidance behaviors. They're treated as phobic conditions, irrespective of formal diagnosis. It's assumed that at the core of the patient's mental problems lies a persistent fear of disintegrating, of being engulfed by total emptiness, or stuck in eternal pain. This fear is referred to as existential catastrophe anxiety. So various forms of avoidance behavior may hold the existential catastrophe anxiety at bay and provide alleviation in the short term, but of course, over time, avoidance can reinforce the patient's symptoms and functional disability. So, seen in a phobia perspective, the therapeutic solution is exposure. In principle, the exposure to this existential catastrophe anxieties undertaken in the same way as exposure to other phobic conditions. I think you guys get a lot out of watching this video. It was a training program that was given over 3 days to folks who were in the process of getting off of psych drugs, or there was a clinician there, a wide variety of people, and you hear what they have to say about what the problems are and what some of the solutions are, what can help, etc. So be sure and watch this. It's about an hour long and it's well worth it. Another video here zeroes in on antidepressants, how to safely get off of them. And you'll find this psychiatric drug withdrawal primer, a great resource, so take some time with that one. It's loaded with usable information. Zeroing in on the use of herbs, this video discusses how to use skullcap for coming off of antidepressants and antipsychotics. Of course, there are online support groups for folks going through this, and one of them you see here. Now let's jump to the section specific to getting off of SSRI antidepressant drugs. just a quick preview of what you'll find in the database. A common symptom of withdrawing are something that can be called brain zaps or an electric shock sensation. So you're only seeing part of the page here, but I'll tell you that this is one of the areas where skullcap helped. Dr. David Healy really goes into detail on the different SSRI drugs and exactly how to get off of them, step by step. In 119 pages, the Council for Information on Tranquilizers and Antidepressants will walk you through how to get off of not only the SSRIs, but also sleeping pills. Here's their SSRI withdrawal protocol. And then there's guidance principles of antidepressant reduction, and as you see here from the contents, guidance is organized to the specific drugs involved. Now, this site, Bloomin' Wellness, not only offers resources for getting off of the benzos and antidepressants, but they also offer support. I thought this was interesting from the Herald that the Royal College of Psychiatrists, the leaders, are accused of dangerous and misleading comments on antidepressant withdrawal. So that's something to check out as well. Now let's move on to the benzos. Benzo withdrawal is potentially a serious condition. It's complex and often protracted. Long-term use, defined as daily use for at least 3 months, is not desirable because of the associated increased risk of dependence, dose escalation, loss of efficacy, increased risk of accidents and falls, particularly for the elderly, and cognitive, neurological, and intellectual impairments. If that's a problem you're dealing with, check out Benzo Withdrawal, the ultimate guide to symptom relief. From the Townsend letter, we have a case report and biochemical rationale for using supplements to speed up benzodiazepine withdrawal. The drug was Xanax, and some of the supplements taken were high doses of niacin and GABA and vitamin C. And you'll notice here that lobelia can also be helpful in getting off of benzos. Of course, you'll need to get into the database to read up on how to use lobelia. It's pretty strong, and you're going to want to know about the dosing and the studies that show it helps with it. And just kind of moving along quickly, there is a video here on how to use herbs to detox, a benzodiazepine withdrawal protocol. And there are a couple of support groups for benzo withdrawal that you'll find here. So there's a lot more in the database. I'm not going to go through all of it, but I think you get the idea that it's very thorough in helping to find solutions to this very complicated problem. Thank you for joining me, and I'd love to hear from you, either by leaving comments here on YouTube, or you could join our Facebook group at Herbal Knowledge Keepers. And meanwhile, subscribe to the channel to get notifications of new videos as they come out. Oh, by the way, there is an archive of all the Herbal Knowledge Keepers videos located on the database website at herbaldatabase.org. See you soon.